Dear colleagues, welcome to WeOncologists ESO Presents. My name is Gil Morgan, and today I have the great pleasure to present not only a great friend, but a terrific scientist and clinician, Dr. Philippe Aftimos of the Jules Bordet Institute in Brussels, Belgium. Dr. Aftimos is the Clinical Trials Development Leader at the CTCU at Bordet, and is also a fellow member of the Oncola Network. Philippe will be presenting today on the current landscape of standard of care and new drug development in HER2 metastatic breast cancer. So without further delay, Dr. Aftimos, the floor is yours.
Greetings to all of you following us today on Twitter. My name is Philippe Aftimos and I am a medical oncologist working on new drug development in breast cancer at the Jules Bordet Institut in Brussels. The subject of the day is the current landscape of standard of care and new drug development in HER2 positive metastatic breast cancer. Please take a moment to look at my disclosures and conflicts of interest. Metastatic breast cancer is a heterogeneous disease. When we decide treatment strategies and options, we need to look at the estrogen receptor expression, the progesterone receptor expression, and the HER2 status. So disease factors are important, but also patient factors are important. So we need to also look at the performance status and comorbidities, the prior treatment, and specifically response to prior treatment. And more, we have somatic and germline mutations being incorporated in treatment decisions. HER2 guidelines, when to test. I think that all societies all over the world are in agreement that all invasive primary breast tumors need to be tested by immunohistochemistry at least for HER2 because this will guide the treatment options. We also know that the metastatic relapse should also be treated because even if it's rare, you might have discordances. And in this paper by Amir et al., we can see that tissue confirmation in metastatic breast cancer is important because even though the discordance between the primary and the metastasis in this paper was only 10%, this is already important for your treatment options. How to test and how to define HER2 positive breast cancer. We follow the ASCO-CAP guidelines of 2018. So ASCO is the American Society of Clinical Oncology, and CAP is the College of American Pathologists. HER2 positive breast cancer is defined as overexpression 3+ by immunohistochemistry. 0 or 1+ score means HER2 negative. And then some tumors will have a score of 2+ by immunohistochemistry, and this needs further testing using in situ hybridization. On this slide, you see the definition of positivity for IHC testing, and this is performed when your score is 2+. And this is how, for tumors with 2+ score, we will determine if the tumor is HER2 positive or HER2 negative. And in the clinical trials that tested novel treatments for HER2 positive breast cancer, patients were included if the tumor was 3+ by immunohistochemistry or 2+ with a positive IHC test. Now, breast cancer is subtyped using immunohistochemistry, and on this slide you can see the pathological and some clinical differences between HER2 positive breast cancer and the other subtypes. So HER2 positive breast cancer remains an aggressive disease. You can see that half of the tumors express the estrogen receptor. 3/4 are grade 3, and you can see also, at least before screening was really prevalent, tumors that were above 2 centimeters and node positive. Patients with HER2 positive breast cancer had a dismal prognosis before the advent of anti-HER2 therapy, namely trastuzumab. On this slide, you can see that the survival curves for HER2 positive breast cancer are the worst compared to the other subtypes. And I repeat, this was before the advent of trastuzumab, and you can see here the curves are the purple curves for HER2 positive breast cancer. Now, the prognosis of patients with HER2 positive breast cancer really was transformed with the advent of trastuzumab. Trastuzumab is a monoclonal antibody targeting HER2. The addition of trastuzumab to standard chemotherapy led to an improvement in progression-free survival and overall survival for patients with HER2 positive metastatic breast cancer, as you can see in the seminal publication by Slayman et al. In the New England Journal of Medicine of 2001. Trastuzumab and chemotherapy became the standard of care. The next question was regarding the progression on trastuzumab, what to do. And you can see here the clinical trial that led to the concept of trastuzumab beyond progression. So patients that had progression under trastuzumab-based first-line therapy were randomized to capecitabine monotherapy versus capecitabine and the continuation of trastuzumab. Capecitabine is an oral chemotherapy, and the study was positive. So beyond progression on trastuzumab in the first line, continuing trastuzumab led to an improvement in progression-free survival. You can see here 8.2 months versus 5.6 months, and overall survival. So the standard of care became trastuzumab beyond progression, meaning keeping trastuzumab in combination with the successive lines of chemotherapy. Now, other HER2 targeting agents were developed, and this was another class. So trastuzumab is a monoclonal antibody, lapatinib, but also other agents such as neratinib, afatinib, and tucatinib are tyrosine kinase inhibitors. So these are oral therapies, small molecules that targeted HER2 differently than did trastuzumab. The pivotal paper that led to the approval of the first agent, that was lapatinib, was a study in the post-trastuzumab setting with a combination of lapatinib and capecitabine, so an oral regimen versus capecitabine alone. And this led to an improvement in progression-free survival, 8.4 months on the combination versus 4.4 months on capecitabine alone. Having at the time two agents targeting differently HER2 was interesting for combination studies, and lapatinib and trastuzumab were tested in combination. On this slide, you can see the study by Blackwell et al., lapatinib plus trastuzumab versus lapatinib, that showed an improvement in progression-free survival and overall survival for the combination versus single-agent lapatinib. This regimen is interesting for patients with brain metastasis, a common and prevalent feature of HER2 positive metastatic breast cancer. Indeed, small tyrosine kinase inhibitor seem attractive as treatment for brain metastasis and active. And I can give you the example of Belgium, where this combination of lapatinib and trastuzumab is only approved for patients with disease progression in the central nervous system. Now, combining anti-HER2 agents, or what is called a double HER2 blockade, became very important with the development of another monoclonal antibody targeting HER2, and this is pertuzumab. As you can see on this figure from the Oncologist journal, pertuzumab binds to another domain as trastuzumab in the HER2 receptor and impedes the dimerization of HER2 and HER3. The pivotal trial that studied double HER2 blockade with pertuzumab and trastuzumab was CLEOPATRA. CLEOPATRA was a study in the first-line setting of HER2 positive metastatic breast cancer. Patients were randomized 1-to-1 to what was the standard of care, taxane-based chemotherapy, here docetaxel plus trastuzumab, versus docetaxel plus pertuzumab and trastuzumab. Patients in the trastuzumab-only arm received a placebo. The primary endpoint of the study was progression-free survival, and secondary endpoints included overall survival. The study was positive, and you can see on these curves an improvement in both progression-free survival and overall survival. What was important is that the overall survival of patients with HER2 positive metastatic breast cancer in the study treated on the pertuzumab arm nearly reached 5 years. So it was 56.5 months. So this was a very important improvement. On the next slide, you can see that the benefit was in all the subgroups. However, look at the red arrow. This is not real life today, because in this study, in the CLEOPATRA study, only 10% of patients had received prior adjuvant trastuzumab. And in our current practice, almost all patients that are diagnosed with early HER2 positive breast cancer receive adjuvant trastuzumab. So even though this regimen is currently the standard of care in the first line setting and is active, I do not believe that we see the same efficacy in the real world setting, because patients would have already received trastuzumab in the adjuvant or neoadjuvant settings. Given that tumors or breast tumors that are HER2 positive are addicted to the HER2 oncogene, new drug development in this field focus on targeting HER2, and a new class of agents emerge. Those are the antibody drug conjugates, with T-DM1 being the first anti-HER2 antibody drug conjugate to be tested in clinical trials and eventually approved. In this figure from Clinical Cancer Research, published in 2011, you can see the concept of antibody drug conjugates. So antibody drug conjugates are monoclonal antibodies, and a chemotherapy agent, a cytotoxic agent called a payload, is linked to the monoclonal antibody using a linker. Now these antibody drug conjugates can be cleavable or non-cleavable, such as T-DM1. The cytotoxics that are used are very potent and had been tested previously as a monotherapy, and the development did not continue because they were very toxic. However, when they are linked to the monoclonal antibody, you would expect to have a very low or even absent rate of free cytotoxic in the blood, so less toxicity and higher potency. T-DM1 was tested in a randomized phase 2 study in the first-line setting versus the standard of trastuzumab and docetaxel. This was before the approval of pertuzumab, so a taxane and trastuzumab was the standard of care. The study enrolled 137 patients, and this study proved the superiority of T-DM1 with an improved progression-free survival compared with trastuzumab and docetaxel. Looking at the toxicity profile, the the toxicity profile of TDM1 was favorable compared to chemotherapy and trastuzumab. This is mainly seen when we look at hematological toxicity. So for neutropenia, the rate was 65% with docetaxel and trastuzumab versus 16% with TDM1. The rate of more than grade 3 and more neutropenia was 62% with docetaxel and trastuzumab and only 5.8% with TDM1. There was no almost no alopecia with TDM1 with an all grade rate of 4% versus 66%. So the results, efficacy and safety were very favorable, and TDM1 was tested in the Emilia phase 3 pivotal study. This was a phase 3 randomized study. Patients with HER2 positive metastatic breast cancer after progression on prior taxane and trastuzumab were randomized to TDM1 or lapatinib and capecitabine. The study was positive with an improvement in progression-free survival, 9.6 months in median for TDM1 versus 6.4 months for the combination of capecitabine and lapatinib. There was also an improvement in overall survival with a median overall survival for patients on TDM1 of 31 months versus 25 months on capecitabine and lapatinib. Looking at the safety profile in this study, the rate of GI adverse events such as diarrhea was higher in the lapatinib and capecitabine arm, as well as the palmar-plantar erythrodysesthesia, which can be seen with both agents, lapatinib and capecitabine. Following the results of the Emilia phase 3 clinical trial, TDM1 was FDA approved and became the standard of care in the second-line setting following treatment with a taxane and trastuzumab. Now, no patients in this trial had received prior pertuzumab because it was not yet approved at the time. Some retrospective series have been published and show that TDM1 remains active after prior pertuzumab, even though the response rate might be slightly lower than in the Emilia trial. Thus, TDM1 is still the preferred second-line therapy following a taxane, pertuzumab, and trastuzumab. The Teresa trial is a phase 3 trial that tested TDM1 in further lines, so beyond the second line. So in this study, patients with HER2 positive metastatic breast cancer must have received 2 or more prior HER2-directed therapies for advanced breast cancer, and they were randomized 2-to-1 to TDM1 or treatment of physician's choice. The co-primary endpoints were PFS and overall survival. Again, the study favored TDM1 with a PFS of 6.2 months versus 3.3 months for physician's choice. Despite the protocol allowed crossover, there was an improvement in the overall survival with TDM1 versus treatment of physician's choice, and we can see here the final overall survival analysis with an OS of 22.7 months with TDM1 versus 15.8 months with treatment of physician's choice. Based on the Emilia and Teresa phase 3 randomized clinical trials, TDM1 became the standard of care in the second line and beyond for patients that did not receive TDM1 in the second line. Now, TDM1 was also tested in a phase 3 study called Marianne in the first line setting. This was a 3-arm study. Patients were randomized to TDM1, T-DM1 plus pertuzumab and trastuzumab and the taxane, the study was negative, meaning that the T-DM1 arms were not superior to the trastuzumab and taxane arm, and this is why pertuzumab, trastuzumab, and the taxane remained the standard first-line therapy, and T-DM1 the second-line therapy and beyond. We have seen in this first part of this presentation active anti-HER2 agents such as trastuzumab, pertuzumab, T-DM1, and lapatinib. But what was the status in early HER2 positive breast cancer? Because drugs that are active in the metastatic setting usually move to the early setting if the studies are positive. And as we discussed previously, prior treatment is important when choosing the treatment strategy for a patient with metastatic breast cancer. So the status in early HER2 positive breast cancer and the neo or adjuvant settings are quite important. The table on this slide summarizes the positive phase 3 studies that led to the approval of trastuzumab in the adjuvant setting. So trastuzumab can have reversible cardiotoxicity, so we do not usually prescribe it with anthracycline that can cause irreversible cardiotoxicity. In these adjuvant studies, trastuzumab was administered either sequentially after the end of adjuvant chemotherapy or during the taxane part of the adjuvant chemotherapy. And in these studies, trastuzumab was administered for a duration of 1 year, except in the HERA trial where there was a 1-year arm and a 2-year arm. These studies led to the standard of care of 1 year of adjuvant trastuzumab in combination and following chemotherapy. One of these studies, the BCIRG-006, also tested a non-anthracycline arm with docetaxel, carboplatin, and trastuzumab that was also non-inferior and also standard of care for selected patients. Now, despite the drastic reduction in the number of relapses with adjuvant trastuzumab, some patients still experienced metastatic relapse, and this led to further clinical trials and treatment strategies. I would like to discuss the ExteNet study. This is a study testing neratinib, an irreversible HER inhibitor, so a tyrosine kinase inhibitor. The study tested neratinib as an extended adjuvant therapy post 1 year of trastuzumab. So patients that had completed 1 year of trastuzumab were randomized 1-to-1 to 1 year of neratinib or 1 year of placebo. You can see here the graph that shows the 5-year invasive disease-free survival, and there was an advantage with extended neratinib versus placebo following 1 year of adjuvant trastuzumab. Now, this came at a price, and you can see a high prevalence of grade 3 diarrhea with neratinib. So the rate of grade 3 diarrhea in the neratinib arm was 40%, and this is very high. Subgroup analysis showed mainly a benefit in the ER positive group. Double blockade was also tested as an adjuvant strategy in the affinity trial. You can see here the design of the phase 3 pivotal affinity study. Patients were randomized after surgery to the prior standard of care, chemotherapy plus trastuzumab, and in this case in the trial, patients also received the placebo, versus chemotherapy plus double blockade using trastuzumab and pertuzumab. The study was again positive. On this slide, you see the 4-year invasive disease-free survival, and there was an improved 4-year invasive disease-free survival with double blockade. you can see that the difference is more important in node positive disease, and this led to the FDA approval of double blockade for 1 year in the adjuvant setting. We have therefore seen a constant improvement of the cure rates with adjuvant trastuzumab, extended neratinib, and adjuvant double blockade with pertuzumab and trastuzumab. But still, a subset of patients would relapse after completing adjuvant therapy and would relapse with metastatic disease. It is important, therefore, to identify those patients in need of therapy escalation or different treatment strategies. On this slide, from the Cortazar et al. Publication in Lancet in 2014, you can see that patients treated with neoadjuvant therapy that do not achieve pathological complete response have a higher rate of relapse. And this is seen both in ER positive, HER2 positive disease, so the triple positive subset, or HER2 positive, ER negative, even though the difference is more important in the ER negative subset. This information is very important because this can allow us to identify the patients that would need treatment escalation. And this is what was used in the pivotal phase 3 Catherine study that tested TDM1 versus trastuzumab as adjuvant therapy in patients with HER2 positive early breast cancer. And this study was limited to patients with residual invasive disease after neoadjuvant chemotherapy and HER2 targeted therapy, meaning the patient population with a higher risk of relapse. On this slide, you can see the Catherine study design. So patients were treated with neoadjuvant chemotherapy plus trastuzumab plus or minus pertuzumab. Patients that did not achieve pathological complete response were randomized 1-to-1 to TDM1 to complete 1 year of anti-HER2 therapy, or trastuzumab, which was the standard of care at the time, to complete 1 year of adjuvant anti-HER2 therapy. The study was reported last year and showed superiority of TDM1 in these patients with a 3-year invasive disease-free survival rate of 88.3% with TDM1 versus 77% with trastuzumab. And you can see the difference also in freedom from distant recurrence, so metastatic disease, 89.7% at 3 years with TDM1 versus 83% with trastuzumab. The Catherine study therefore led to regulatory approval. On May 3rd, 2019, the FDA approved TDM1 for the adjuvant treatment of patients with HER2 positive early breast cancer who have residual invasive disease after neoadjuvant taxane and trastuzumab-based treatment. These few slides on the treatment of early breast cancer HER2 positive showed us that the most active approved drugs are now being used in the early setting, namely trastuzumab, pertuzumab, TDM1, and neratinib. So this will prove a challenge for the treatment of HER2 positive metastatic breast cancer after dual blockade and TDM1. And on this slide, I have summarized the challenges for new drug development in HER2 positive metastatic breast cancer. Indeed, despite optimal neoadjuvant or adjuvant therapy, the risk of relapse remains between 10% for node positive disease in the Catherine study and 14% in the Affinity study. Furthermore, we have patients with primary resistance to first-line therapy with a taxane, pertuzumab, and trastuzumab, and the rate was 4% in CLEOPATRA, knowing that patients in CLEOPATRA it was a minority of patients in CLEOPATRA that received neoadjuvant or adjuvant trastuzumab. So this rate of 4% would be much more in the real-world setting. Resistance to systemic therapy develops in the vast majority of patients with metastatic breast cancer, with fewer than 40% of patients surviving longer than 7 years after diagnosis. Brain metastasis. So more than 30% of patients with HER2-positive metastatic breast cancer develop metastasis in the central nervous system. And this is an area of unmet need because of the mortality and comorbidity of this complication. Finally, to date, there is no validated biomarker beyond HER2 amplification for anti-HER2 therapy. Now, new drug development in this setting has continued with novel HER2 antibody-based development. I try to summarize these developments in this table, where you have different classes of antibodies. You have novel antibody-drug conjugates targeting HER2, you have bispecific antibodies, and you have FC-optimized antibodies. The most promising, or at least the most advanced in development, are the novel anti-HER2 antibody-drug conjugates. So TDM1 was the first one to be approved, and the payload DM1 is a microtubule inhibitor. Some of these novel antibody-drug conjugates are being constructed with a payload with a different mechanism of action, such as deruxtecan, which is a topo-1 inhibitor, or duocarmycin, that is a minor groove binder. And we can see in this table 5 anti-HER2 ADCs, knowing that the third one, ADCT-502, has been discontinued. So the development has been discontinued. To the next slide, where I focus on one of these novel ADCs, SID985. This is the ADC with the payload that is a minor groove binder. You can see here the experiments in the preclinical setting, and on and in these models, SID985 proved to be more potent than TDM1 in HER2 positive, so 3+ expression by immunohistochemistry models, but also in HER2 negative models that you can see in panel B and C. This led to a phase 1 study. This was a dose escalation, but with also a breast cancer expansion cohort. You can see here the results that were published recently. So this is the HER2 positive breast cancer cohort. So a heavily pretreated patient population. So 42% of patients had received more than 6 lines of previous anti-cancer therapy. 30% had been previously pretreated with pertuzumab, and 80% had previous TDM1. The waterfall plot shows a response rate of 33%, and progression-free survival was 7.6 months. Looking at the toxicity profile, many antibody-drug conjugates are known to cause ocular toxicity, and this was seen with SID985. So the most prevalent toxicity was conjunctivitis, but there was also keratitis, and this can be a limiting factor for repeated dosing, as it is the case with neurotoxicity with taxanes. For example, there was an 8% rate of grade 1-2 pneumonitis in the dose escalation part of the study, and 1% grade 4 pneumonitis in the dose expansion part. So since a phase 3 study is currently ongoing, it's very important to look out for pneumonitis. Trastuzumab deruxtecan, or DS-8201, is another very promising anti-HER2 ADC in HER2 positive metastatic breast cancer. You can see here the results from the HER2 positive metastatic breast cancer expansion cohort, heavily pretreated population. So 82% of patients had received 5 or more prior anti-cancer regimens, 86% had received prior pertuzumab, and 100% had received prior TDM1. The waterfall plot is very eloquent. The objective response rate was 59.5%, and the progression-free survival 22.1 months. Looking at the adverse events profile, gastrointestinal toxicity seems most prevalent. 5% of patients had grade 1, 2, or 2 pneumonitis, and there were 2 cases of deadly pneumonitis. And again, in the phase 3 trial that is ongoing, investigators need to be careful with these events. Now, there are 3 ongoing phase 3 trials in HER2 positive metastatic breast cancer with these novel ADCs. So the TULIP trial, the phase 3 trial testing SID985 versus treatment of physician's choice. And there are 2 studies with DS-8201. The first one is Destiny 2, testing this agent in the heavily pretreated population, so after TDM1, and the Destiny 3 study is another randomized phase 3 study testing DS-8201 versus TDM1, so this would be the second line setting. Switching gears to novel naked antibodies, the SOPHIA phase 3 study was presented recently at the American Society of Clinical Oncology annual meeting. This study was a randomized phase 3 study of margetuximab plus chemotherapy versus trastuzumab plus chemotherapy in patients with HER2 positive metastatic breast cancer after prior anti-HER2 therapies. So margetuximab is an Fc engineered anti-HER2 monoclonal antibody with the goal to activate immune responses, as you can see in this slide. The next slide shows the SOPHIA study design. Patients with HER2 positive advanced breast cancer that had received 2 or more prior anti-HER2 therapies, including pertuzumab, were randomized 1-to-1 to margetuximab plus chemotherapy versus trastuzumab and chemotherapy. You can see the table showing the patient characteristics. In both arms, 100% of patients had received both trastuzumab and pertuzumab, and the vast majority of patients had received TDM1. The progression-free survival analysis in the intention to treat population showed a modest benefit with margetuximab. However, a planned exploratory PFS analysis in patients with a specific genotype, CD16A, showed that this genotype could be a predictor of benefit with margetuximab, leading to the conclusion slide showing that margetuximab indeed improved progression-free survival, overall objective response rate, and clinical benefit rate compared with trastuzumab plus chemotherapy, that there was a benefit prediction using the CD16A genotype. The safety profile was acceptable with more infusion-related reactions when compared to trastuzumab. Now, how to incorporate this novel agent in our armamentarium? I believe that this monoclonal antibody can be tested in earlier lines to see if we can increase cure rates. Novel anti-HER2 small molecule tyrosine kinase inhibitors continue to be developed. I will briefly mention the tucatinib because you can see in this slide that this agent appears promising specifically in patients with brain metastasis. There is a randomized study currently ongoing, starting in the third line setting and beyond. It's called HER2 Climb. Just put this slide to show you that patients with untreated or progressive brain metastasis are eligible for the study. And I think this is a very important information, and we hope that the benefit will be important in this population with an unmet medical need. I would like to switch gears now to other possible combinations with anti-HER2 therapy remaining the backbone. So other combinations include combinations with CDK4/6 inhibitors, but also immune checkpoint inhibitors. In cell lines, CDK4/6 inhibitors that are standard therapies in ER-positive, HER2-negative metastatic breast cancer have been shown to overcome resistance to trastuzumab when given in combination with anti-HER2 therapy. And there are ongoing studies in HER2-positive metastatic breast cancer with a combination of CDK4/6 inhibitors such as palbociclib and abemaciclib and ribociclib with anti-HER2 agents such as TDM1 or trastuzumab. And there are also triple combinations with estrogen receptor antagonists in triple-positive disease. Very recently, at the latest ESMO conference, the Monarch-HER study was reported. So Monarch-HER is a randomized study with 3 arms. Arm A is a triple combination of the CDK4/6 inhibitor abemaciclib in combination with trastuzumab and fulvestrant, a selective estrogen receptor degrader. In Arm B, the combination was abemaciclib and trastuzumab, and in Arm C was trastuzumab and investigator choice of chemotherapy. Eligibility criteria included triple positive advanced breast cancer, so both hormone receptor positive and HER2 positive. Patients must have received 2 or more prior anti-HER2 therapies. Prior TDM1 and taxane was required. Patients should have been CDK4/6 inhibitors and fulvestrant naive, and no untreated or symptomatic CNS metastasis. The primary endpoint was progression-free survival, and the intention was to compare the triple combination of abemaciclib, trastuzumab, and fulvestrant to chemotherapy, and the double combination of abemaciclib and trastuzumab to chemotherapy. The results for the primary endpoint, which was progression-free survival, showed that there was a statistically significant improvement with the combination of abemaciclib, trastuzumab, and fulvestrant versus chemotherapy and trastuzumab, with a PFS of 8.32 months for the triple agent combination versus 5.69 months median for trastuzumab and chemotherapy. So very important results that might lead to chemo-free regimens in triple-positive disease. Now switching to immunotherapy, a very hot topic in recent years with anti-PD-1 agents being approved in different cancer types. Regarding HER2-positive breast cancer, it has been demonstrated that HER2-positive breast cancer has high levels of T-cell infiltration, that tumor-infiltrating lymphocytes are associated with improved prognosis and response to trastuzumab and chemotherapy. Trastuzumab has been shown to have immune-mediated mechanisms of action, and preclinical studies have showed potential synergy between checkpoint inhibition and anti-HER2 therapy. And this was the rationale for the study design of Panacea. Panacea is a phase 1-2 clinical study that tested the combination of pembrolizumab and anti-PD-1 monoclonal antibody in combination with trastuzumab. In the phase 2 expansion part, a fixed dose of 200 milligrams of pembrolizumab was used. Patients with PD-L1 positive and PD-L1 negative HER2 positive breast cancer were enrolled. PD-L1 and HER2 status were determined in a central lab. Next slide shows the objective response rate that was 15% for HER2 positive, PD-L1 positive disease, and the response rate was much less in PD-L1 negative disease. I will now discuss the potential for combining endocrine therapy, anti-HER2 therapy, and inhibitors of the PI3K AKT mTOR pathway. Indeed, this slide shows that endocrine therapy has been given in combination with anti-HER2 therapy previously for the treatment of HER2 positive metastatic breast cancer and positive hormone receptors. Indeed, the combinations of letrozole and lapatinib or anastrozole and trastuzumab showed superior results to the endocrine therapy alone, so either letrozole or anastrozole. However, the extent of benefit was not very important. At the same time, this paper published in Cancer Cell in 2007 showed that the PI3K AKT mTOR pathway is a pathway that drives resistance to trastuzumab and other anti-HER2 agents. You can see that low PTEN expression due to PTEN loss of function or activation of the PI3K pathway by PIK3CA mutations, activating mutations, for example, led to shorter progression-free survivals. Now, everolimus, an mTOR inhibitor, has already been tested in the HER2 positive metastatic breast cancer field in 2 randomized phase 3 studies, Bolero-1 in the first-line setting and Bolero-3 in the second-line setting. Everolimus was given in combination with chemotherapy, and the results were not practice-changing. However, they were hypothesis-generating because we can see that selecting patients based on biomarkers might allow us to prove better efficacy. We have new opportunities today with novel anti-HER2 agents that are now being used in the early setting, so we are in need of new treatment strategies. We have the development of more specific inhibitors of PIK3CA, and we can test the strategy in an enriched population and not all comers. There has been multiple initiatives to interrogate the molecular portraits of human breast tumors, and on this oncoplot you can see that PIK3CA mutations can be seen in all subtypes of breast cancer, including HER2 positive breast cancer. Now recently, the SOLAR-1 phase 3 study that tested the combination of endocrine therapy and the PIK3CA specific inhibitor alpelisib in ER-positive HER2-negative metastatic breast cancer, and this study proved the concept. Indeed, both PIK3CA mutated tumors or PIK3CA wild-type tumors were randomized to alpelisib plus fulvestrant or placebo plus fulvestrant, and the benefit with alpelisib was only seen in the PIK3CA mutated cohort, with a progression-free survival median of 11 months versus 5.7 months in the placebo arm. This study provides, therefore, the rationale to test PIK3CA inhibitors in combination with anti-HER2 therapy plus or minus endocrine therapy in HER2-positive metastatic breast cancer and PIK3CA activating mutations. I show on the slide the design of the BPrecise-01 study testing a novel PIK3CA inhibitor, MEN1611, in combination with trastuzumab in HER2-positive ER-negative metastatic breast cancer, and in combination with trastuzumab and fulvestrant in HER2-positive and ER-positive metastatic breast cancer. And the dose escalation part of the study is almost completed, and the cohort expansions will begin, and we expect a readout in the coming months or years. We come now to the last part of this presentation, and I would like to focus on what is called HER2-low breast cancer. Indeed, we have historically looked at HER2 as positive or negative, but we have data now showing that HER2 can be looked at as a continuous variable. Indeed, HER2-low breast cancer is currently defined in clinical trials immunohistochemistry score 1+ or 2+-ish negative. So historically, these patients would not be treated with anti-HER2 therapy. There are also HER2 activating mutations in tumors that are HER2 negative by definition because without the HER2 amplification. This slide shows the difference between HER2-low and HER2-positive breast cancer using immunohistochemistry. So on the left, you see a slide of a tumor that is IHC2+-ish negative, and on the right, a tumor that is IHC3+. So despite the tumor on the left being called HER2 negative, you can still see some expression of HER2. Now, a large study had already tested trastuzumab as adjuvant therapy in HER2-low breast cancer, and this study was negative. And we know that the current approved therapies for HER2-positive breast cancer, such as trastuzumab, pertuzumab, or T-DM1, do not work in HER2-low breast cancer. This next slide explains the concept of bystander killing. And this concept could explain the activity of anti-HER2 antibody-drug conjugates that are more potent than T-DM1 in HER2-low breast cancer. So the payload can diffuse from one cell to another, from a HER2-positive cell to a HER2-negative cell, thus explaining the activity of these novel anti-HER2 ADCs. On this slide, I show you the results from the expansion phase of SID985. So there was a cohort for HER2-low hormone receptor positive metastatic breast cancer and the cohort for HER2-low triple negative breast cancer. And you can see that some patients did respond to therapy with partial responses. The same was seen in the expansion phases of the study testing DS8201. You can see here the waterfall plot from the HER2-low breast cancer cohort with patients experiencing tumor shrinkage. Now, I briefly mentioned HER2 mutations. This slide explains the difference between HER2 amplification and HER2 mutation. So HER2 amplification is an increase in the number of copies of the HER2 gene without an increase in other genes. And this is the biomarker that is targeted by HER2 therapy, and this is what we look for currently when we treat breast cancer. Activating HER2, or the name of the gene ERBB2 mutations, are somatic point mutations in ERBB2 that activate the pathway. And you can see on this figure on the right that most of these mutations occur in the kinase domain. Now, what is the role of ERBB2 mutations in HER2 non-amplified breast cancer? They have been proven to be oncogenic. Their prevalence is in 1.6 to 2% of breast cancers, but they can be more prevalent in some subtypes of breast cancer, such as lobular breast cancer. They mediate acquired endocrine resistance, and they can be targeted by pan-HER inhibitors. The SUMMIT trial is a basket trial. Basket trials are trials where patients with different tumor types, but a common molecular alteration, are treated with the same drug. So in the SUMMIT trial, patients with different tumor types and activating ERBB2 mutations were treated with neratinib. There were two cohorts for patients with metastatic breast cancer that was HER2 negative. So a cohort for patients with hormone receptor negative breast cancer and a cohort with hormone receptor positive breast cancer. You can see in this waterfall plot some responses, mainly in patients with metastatic ER positive, HER2 negative breast cancer treated with a combination of neratinib and fulvestrant. This concludes my presentation today, and here are a few conclusion messages. So the development of novel anti-HER2 therapies has led to an important improvement in the outcomes of patients with HER2 positive breast cancer. Novel therapies, ADCs, bispecific vaccines, and novel combinations such as with immunotherapy or CDK4/6 inhibitors are being developed to treat relapses after prior treatment. Brain metastases remain an important unmet need. Novel anti-HER2 therapies are active in metastatic breast cancer with low HER2 expression and HER2 mutated breast cancer. So targeting HER2 in breast cancer and maybe in the future in other disease types has been a very important advance in oncology. This is why in 2019, the Lasker-DeBakey Clinical Medical Research Award went to scientists involved on their work on HER2 in breast cancer. And with that, I would like to thank Gil Morgan and the European School of Oncology for the opportunity, and I hope we can connect in the future.